Hello, Section 3. Again, I hope you guys are doing well. We're in week 6 and plugging along. I know some of you may even be at weekend intensives this weekend as everybody tries to catch up with that hands-on aspect of the program. And if you are, hope you've learned a lot. And last week, for those of you who were there last week, I hope you learned a lot as well, because this was just a great opportunity to take what you've learned, the didactic information, if you will, and then directly apply it with the hands-on aspects of it, and then really learn to fine-tune your skills. So, upper extremity management, week 6, adhesive capsulitis, and obviously proximal humeral fractures. Some interesting stuff that we're going to talk about, or that we did talk about, and I just want to quickly kind of refresh everybody. And the stages I think are really important when we look at the Bob Boyle's presentation. I think he did a really good job of kind of helping all of us put into perspective. And why this isn't so important, because we know that education is a huge part of what we should be helping our patients understand. If they get that this is a long haul issue, or at least an issue that doesn't have a quick fix per se, and I oftentimes tell them, listen, we're going to get this so that you can sleep at night and so that you're functional in your mobility, but it may take a while before you get that end range motion. And they're totally fine with that, especially if they know if you can get them comfortable. That's a big deal. And that female diabetic 40 to 65, that's the kind of person you need to have in the back of your head. If it's a non-traumatic, like, why am I confused here about this shoulder person? Why doesn't it not look like an impingement or a rotator cuff or what have you? And understand the differences. Appreciate the level of irritability. So those people who are really, really painful. I think we have a couple of things at our disposal. We'll talk about those later on, whether that be dry needling or manipulation and mobilization of from a regional interdependence perspective. Use those, okay? But if you can't get it down, off to get an injection. And we'll talk about the other stuff that we talked about related to translational manipulations just in a second. Oral steroids have shown some significant short-term benefit, but again, they don't last long, and at 6 weeks, it's really no benefit. When we go to look at the clinical guidelines, corticosteroids offer short-term relief. Again, we're creating that window of opportunity. What is the window for? It's to move it and to loosen it up, and for you to be able to be more aggressive with their daily routine, and being able to touch their shoulder so that they don't have a ton of pain with what you do. Patient education, we've already talked about that, getting a B rating. Stretching exercises, again, B rating. And then, modalities and mobilizations have yet to really come to light. I think that translational manipulation research, there's another study coming out, and there was one already done, that are going to continue to build on that. So I think you're going to see that get higher. And I know there was a lot of discussion about the translational manipulation and how for a lot of people it's just not on their radar. And does that mean that it shouldn't be? Does that mean that we don't need to form professional relationships with people and help others understand that this is good for the patient? I would... So be thinking about that. The trigger point dry needling stuff, this is new stuff. This is the beginning of, I believe, again, a lot of literature to come out on dry needling. But pay attention to it. Engage colleagues with it. Is this for us? Is this, I dry needle. I am definitely intrigued by the possibilities. And the research I think that comes out is gonna support it. I think it's gonna be kind of exciting. The question is, how long does it last? I say it's good for pain modulation. Are we affecting the nervous system? Are we dampening down that signal that's sending that to those muscles? In the Cluey article, after 2 visits, man. And if I had a hot shoulder that was really irritable and the patient was really uncomfortable, and I could get it calmed down in 2 visits, and I don't have to send him to get a steroid, it's just more power to me, right? The opportunity for quicker change is what we're really looking for. So I think that for those of you who are not exposed to dry needling, keep it on your radars. Follow the literature. Know what it says, because I think ultimately, if it does bear to be out to be a good thing, we need to be able to hop on that and use it if the research supports it, as well as if it doesn't. So the Boyle's article in regards to interscalene anesthetic blocks and translational manipulation, it's a great program, and we need to continue to look at this. I think the ends were pretty small, but I think it's a great opportunity, and I have we need to be forging relationships, I believe, with anesthesiologists. I don't think the orthopedists are going to want to touch this with a 10-foot pole, because this is going to take them out of the picture. They would really have nothing to do with this, and we need to forge relationships with anesthesiologists. And I have a friend who's an anesthesiologist. She was like, yeah, I'd do this if you wanted me to. Now, I don't work with her. She works in California, but she certainly was open to this. And I think that if we can justify it, it would be, and then reimbursement, it would be really interesting to see how then that reimbursement kind of carried over. Okay, so my thoughts about this week, just kind of giving you my clinical impressions. Again, consider regional interdependence for improvements. I think we need to be looking at mobilizing cervical spine and thoracic spine, manipulating those to dampen down pain. Okay, so if you're not doing that, you need to start doing that. That will help you. If we are solely focused on the shoulder, we're missing the bigger picture. So low grade versus high grade, having some similar effects. Some of the literature out there, I shared some literature with some of the folks, demonstrates, which always surprised me a little bit, because I'm all about getting in there and getting after it. Low grade, grade 1, 2 kinds of mobilizations offer the same level of pain modulation ultimately as high grade, which, for those who are in a lot of pain, you don't have to be moving that joint excessively. So be thinking about that when you go in and work with these patients, as well as if you feel like, I'm not very strong, I have to use my body mechanics, I have to use a belt, all this stuff to feel like I'm really mobilizing the joint. Well, maybe you don't really need to do that. So be thinking about that. And then I had an interesting conversation with a couple of different folks about what we're doing. A lot of people like to use, Graston, ART, soft tissue mobilization, kinds of soft tissue techniques, and what are we really doing there? My thoughts are, I teach soft tissue techniques to the University of Minnesota, and I really stay away from things like adhesions, restrictions, scar tissue, because none of that stuff is really borne out to be true. The way I approach it in my lectures is that it's more really about tone, decreasing tone from an abnormal response from the nervous system. We know that the adhesive capsulitis is really more about the nervous system because it's this abnormal response. We don't really know why, hence the idiopathic. But so I try to approach it in terms of me decreasing tone and abnormal tone, and that I'm softening tissue. The tissue is softening under the pressure of my hands. You get some pretty amazing responses with soft tissue. So believe you me, I'm all about getting in there and working on soft tissue. I don't think you have to do it for very long to see fairly quick changes, and in being fairly specific in your approach. But I do think that the words that we use and the images that we create for the patient are really important. And so be thinking about that as you describe what you're doing to the patient, and know that, how you phrase things is critical. Okay, so those are my thoughts on this week's stuff. Proximal humeral fractures are important, and I think that we obviously need to continue to mobilize them early and often. And for those who aren't, the research is very good in our favor in regarding getting our hands on those people. And so I would just say, for whoever, if you see enough of these, I actually just got done seeing one. She happened to get sent early. That's not a huge issue with my system or where I'm at. People get referred fairly early. But if you're not, it's good literature. And believe you me, whether it be an internal medicine or family practice or orthopedist, if you show them some kind of literature, they're at least going to have to talk about it. They can't disregard it. And it's always, that's what you come with. And that always backs whatever kind of request you're trying to make. Okay, so moving on to week 7. Oh, this is a good topic. Rotator cuff tendinopathy, biceps tendinopathy, shoulder instability, that whole rotator cuff impingement, tendinopathy, partial tear, bursitis, all of that is kind of falls under this huge big umbrella. It's just a garbage term. I talked about it in impingement. We'll talk about it again with these terms. And man, I work closely with not closely, but close enough with Paula Ludwig, who is one of the leading researchers on shoulder kinematics, and I do believe that she will ultimately kind of formulate some subgrouping categories for shoulder pain and dysfunction, and she's got a couple of good articles out there already. And she thinks this is all one big category, and we need to find out people who respond to specific treatments. Maybe there's some that are going to be better with RI. Maybe there are going to be some that are better with specific cuff strengthening exercises, scap strengthening exercises, nerve mobilization. We need to find those people, and we need to find and to give them the appropriate treatment. Group projects, I think people have gotten into that. I haven't heard any problems with that. You've done the subjective, start into the objective, keep pounding it away, and then we'll post then for week 8, and everybody will start to comment on the good stuff that you've done. If you have any questions, please feel free to let me know. Otherwise, we'll see you after week 7. Keep up the good work, and look forward to reading all of your good stuff. Take good care. Bye-bye.